The case I'm going to present is coming from Tony Shueri from Dana-Farber, but it was at the time I was enjoying a sabbatical there. So it's the case of a 39-year-old female who presents on April 2008 with a lower back pain. And a mass was discovered that was going through the renal vein up to the right atrium. And on May 2008, she underwent a radical nephrectomy with excision of the vena cava, with the atrial thrombus and regional lymphadenectomy requiring cardiac bypass and hypothermic arrest, as has been presented this morning. So the pathology of this tumor was a clear cell with sarcomatoid features, 30% of sarcomatoid features, and this is important to remember. And then 3 months when repeating the CT, recurrence was detected with two large peritoneal implants, 3.2 and 3.4, and also a left adrenal metastasis. The patient didn't have impairment of LDH, calcium, and creatinine clearance, and the patient was included in a phase 2 clinical trial that has mention of the combination of gemcitabine sunitinib, who is designed specifically for patients having sarcomatoid histology, and we will discuss later on. So this patient obtained a very good response, 80% shrinkage, with several toxicities, fatigue, hypertension, neutropenia, and thrombocytopenia, needing dose reductions and some interruptions. However, after 6 months, this patient was admitted on April 2009 with acute renal failure, with a creatinine of 4, proteins in the urine 2.5 grams, anemia, low platelets, and also in the peripheral smear there were some schistocytes, few red blood cell fragments, no CNS symptoms or fever. The last cycle was administered on March, and a renal biopsy was obtained with this patient. And you can see here, this is a typical case of a patient having hemolytic uremic syndrome or thrombotic thrombopenic purpura arterial lumen, completely occluded, just as seen in these entities. You can see here the glomerulus completely collapsed. And you can see here this feature that is a glomerular basement membrane thickening, what is called double contours. It's a renewal of the endothelial membrane that is seen in this type of toxicities. However, obviously the treatment was stopped, but the patient recovered pretty well, and upon restaging there was again a progressive disease at the left adrenal gland. And the treatment here was decided just to re-challenge sunitinib alone, as shown here. However, as you can see here, those are CT scans from August and October. You can see here that there was a progressive disease when receiving sunitinib alone. This patient was subsequently included in this trial that has been mentioned, so immunotherapy might have a role even in these situations. This is the MDX-1106. David McDermott is the PI of the study, and we have heard that we're going to hear more about this treatment. So this is a monoclonal against a programmed cell death, and it seems like an anti-CTLA-4 treatment that probably we are more familiar with. And as you can see here, this patient, here are the scans from October until May 2010. You can see here there is a progressive shrinkage of this adrenal mass, so showing response to immunotherapy at these stages of the disease. So the patient did tolerate pretty well this monoclonal antibody and until the patient subsequently progressed. So this case illustrates what we can find in patients having these sarcomatoid RCC tumor types. And here just to mention that in fact sarcomatoid is not a distinct histologic subtype. We need to remember that, because this can occur in clear cell papillary chromophobe as a component. So it's unusual to find 100% sarcomatoid component, although we can find it. We know that this is an aggressive, rapid growing disease with poor prognosis, and there is little data on the best therapy for this entity. We have here, this is an example. This is taken from this publication JCO. You can see here the clear cell component, and just besides the clear cell component, you can see here these spindle cells with only seen the nuclei, so the cytoplasm is completely collapsed. So meaning that this is a component observed in this clear cell carcinoma. Chemotherapy. What we have about chemotherapy in the sarcomatoid RCC, you can see here a list of clinical trials using combination chemotherapies that have been used in sarcoma tumor types. Bernard reported the combination Adria ifosfamide. As you can see here, no responses. The most recent report and the larger trial has been this ECOG trial. Naomi has reported at ASCO the combination of adriamycin, gemcitabine, 1 complete response, 5 partial response. And we can see here that the median overall survival for this patient population, 3.9 months in this trial, 8.8 months. So very poor outcome in those patients when receiving chemotherapy. What about the use of anti-VEGF targeted therapies? The large report we have is this retrospective collection of patients treated at Cleveland Clinic, where 43 patients having sarcomatoid features and treated with sunitinib, sorafenib, so different anti-VEGF targeted therapies. The response was reported. You can see here the overall response rate, 19%. The partial responses were only seen in patients having the clear cell subtype, and the median progression-free and overall survival 5.3, and the median survival of 11.8 months, so inferior survival as we might expect in patients having pure clear cell histology. Other series have been reported about the use of anti-VEGF targeted agents. Here is a retrospective, so we do not have yet published prospective trials or collections of patients. We can see here 63 patients retrospectively collected from Memorial patients, 29 patients being treated with sunitinib, 14% response rate, progression-free survival of only 4.4 months. Almost no responses using interferon in these histological subtypes. And what is the rationale behind of using anti-VEGF targeted therapies in patients having sarcomatoid component? And this is from a paper published in Journal of Urology. And you can see here the immunohistochemical expression of hypoxia-induced pathway markers in epithelial and in sarcomatoid components of clear cell and non-clear cells. So the expression of these angiogenic markers is present in patients having sarcomatoid histology. So there might be a rationale for using anti-VEGF targeted agents in these histological subtypes. Also, c-KIT is being expressed in the sarcomatoid component in these tumor types, and also PDGF receptor is being expressed, so potential targets for using anti-VEGF targeted agents. One important thing, the percentage of sarcomatoid histology. I think that this is critical whenever we are going to decide what to do with our patients. And this is coming from Goldashan, this retrospective collection of patients are treated at Cleveland Clinic. And you can see here when you split out patients having between 0 or 20% component of sarcomatoid histology, you can see here that the median overall survival is 14.9 months, the median PFS 6.8. However, when those patients receiving targeted agents have a more than 20% component of a sarcomatoid component, you can see here that the median survival goes down to 8.6 and the PFS is going down to 4.3. So the percentage really matters, and at least this threshold of 20% need to be bared in our minds. The other way around, does sarcomatoid percentage of component matters in terms of chemotherapy response? And the answer is probably yes. Obviously, we have limited data, but you can see here, those are from reports using this ifosfamide, adriamycin, DTIC chemotherapy using sarcoma. 1 partial response in patient having more than 95% component of a sarcomatoid feature. In patient receiving Adria ifosfamide, 1 CR in a patient having 100% of sarcomatoid features. And here in this ECOG report, not yet published, by Naomi Haas, presented at ASCO GU, you can see here that 3 partial responses in patients having more than 75% sarcomatoid features. So as more sarcomatoid component you have, more probability to have a response when using chemotherapy. So then the rationale comes to combine anti-VEGF targeted agents and chemotherapy, and this is the rationale behind this trial that the PI is Dror Michelson from Mass General, the combination of sunitinib and gemcitabine in those patients having sarcomatoid differentiation. Also, they did include patients having poor risk features. And as you can see here, this trial was preliminarily reported at ASCO, 5 patients with sarcomatoid differentiation, 2 partial responses, 2 disease stabilization, and 1 progressive disease. So yesterday I contacted him just to know the update about this trial, and they have included 35 out of 36 patients with sarcomatoid, 25 out of 36 with poor risk, and the original numbers are holding up, and this is directly from the email I received, very well tolerated and robust response rate, and this is a personal communication. So probably we're going to know about the final results of this trial in the next year. So just to conclude and to summarize about sarcomatoid RCC, the data is limited. So patients with sarcomatoid demonstrate response to VEGF-targeted therapy. One important thing, patients with clear cell histology and those with lower percentage of sarcomatoid elements may have better outcome with anti-VEGF therapy. In high percentage sarcomatoid, probably chemotherapy works better, and the best option obviously is a clinical trial. We have now 3 clinical trials ongoing. This is nizartanib from MD Anderson combining capecitabine, gemcitabine, and bevacizumab in patients having sarcomatoid histologies. This is the Dror-Michelson trial combining sunitinib and gemcitabine, and this is a trial recently opened in the ECOG trial where patients are randomized to receive sunitinib plus minus gemcitabine and stratify based on the percentage of the sarcomatoid component. What we're doing in our daily clinical practice, we are offering patients having more than 20% sarcomatoid component, the combination of gemcitabine, capecitabine, sorafenib that we published in Lancet Oncology. We have limited experiences, only 4 patients treated. And with that, I would like to acknowledge Tony Shueri, who provided this case presentation that is quite illustrative, and also Dror Michelson, who updated about this clinical trial. Thank you very much.